Hello, and welcome to the Melanoma International Foundation Melanoma Research Alliance webinar series. This is Louise Perkins, Chief Science Officer of the Melanoma Research Alliance. Today we are pleased to bring you one of the foremost experts in melanoma, Dr. Jeffrey Gershenwald, to provide an overview of surgical treatments in melanoma. Dr. Gershenwald is a professor of surgery in the Department of Surgical Oncology and a professor in the Department of Cancer Biology at the University of Texas MD Anderson Cancer Center in Houston, Texas. Dr. Gershenwald's research focuses on clinicopathological and molecular-based staging and prognostic assessment in melanoma and molecular mechanisms of melanoma progression. Dr. Gershenwald is a member of the Surgical Oncology Board of the American Board of Surgery. He is also a member of MRA's Grant Review Committee and Medical Advisory Panel. Welcome, Dr. Gershenwald.
Thanks, Louise. Today we're going to talk about surgical management of melanoma. And what I'd like to do for this session is to provide some foundational background on the surgical treatment of early-stage melanoma. That includes wide excision, as well as the role of lymphatic mapping and sentinel node biopsy, surgical management of regional metastasis, and these include lymph node disease, as well as an interesting and important type of regional metastasis known as in-transit or satellite disease. We'll also discuss surgical treatment for stage 4 or distant metastasis and its role in the evolving landscape for treatment of advanced disease. And we'll also touch on some new frontiers in surgical management of melanoma in 2015. We'll start first with the patient who has a newly diagnosed primary cutaneous melanoma. And when we think of this from a clinical perspective, we usually think of two themes to manage such patients. One is, how do we treat the primary tumor site? How do we treat the melanoma that's just been diagnosed, generally on the skin? And for that, we usually employ what's called a wide excision, and we'll talk about that in just a moment. And then for some patients who are considered to have sufficient risk of regional lymph node metastasis, where regional lymph node spread is the most common first site of spread, we want to consider how to approach the regional lymph node basin, and we'll touch on that as well. So first, how do we treat the area where the melanoma was actually diagnosed? I mentioned that the surgical approach is called wide excision, and we do this with margins that are appropriate for tumor thickness. And what do I mean by that? Well, based on how thick the tumor is, and on the left of this table are tumor thickness ranges, we use different margins that we measure out from the periphery or the edge of the melanoma or the biopsy site, and comprise, for example, for melanomas that are between 1 and 2 millimeters, a 1 to 2 centimeter margin of excision. So we'd measure 1 to 2 centimeters in all directions from the edge of the biopsy site. And what does that look like? In this schematic, the central dark area would be either the residual intact melanoma or the biopsy site. And in this case, this particular melanoma was thick enough to recommend a 2 centimeter margin. And I think you could appreciate that there's a purple oval that corresponds to a 2 centimeter measured surgical margin that we would employ. The gray markings would be representative of some of the additional tissue that we may be removing in order to facilitate a primary closure and to distribute the tension from the wide excision. And the reason we make those kinds of considerations is that unlike for other kinds of skin cancer, for melanoma, the wide excision goes down to the level of the underlying muscular fascia, or the lining of the muscle below the fatty tissue. So the wide excision includes not only normal appearing skin adjacent to where the melanoma was diagnosed, but also all the fatty tissue below. And if we look at that from a broader perspective here, in the top left panel is the wide excision being performed for the melanoma here on this schematic patient's biceps. And then in the bottom right box, we could see the primary closure that could be achieved by freeing up the tissue on both edges, both sides, locally advancing that tissue and then closing up primarily. There are all different kinds of reconstructions that may be necessary, but that's beyond the scope of what we'll talk about today. For many patients who have a newly diagnosed primary melanoma, we need to consider not only the primary tumor site, but because of what's thought to be sufficient risk of microscopic spread of the lymph nodes to the draining lymph node area or the regional nodal basin, we consider an approach that helps us to address the question of whether there's a relatively non-invasive and accurate way to determine which patients have lymph node involvement in their regional lymph nodes and which do not. And historically, we had two choices. Either we removed none of the lymph nodes, that is, we did a wide excision alone and watched clinically the regional nodes for potential development later, or we removed the whole compartment of lymph nodes that we call surgically a lymph node dissection or lymphadenectomy. But if only about 15 to 20% of the patients who were offered this procedure overall, that is some sort of surgical assessment of the lymph nodes, actually had lymph node involvement, we know that about 4 out of 5 patients for whom we offered the procedure really had no potential to benefit because there was no lymph node involvement, but all the potential risks and complications of lymph node surgery. And so this led to the development of new strategies, and one pioneered by the late Dr. Don Morton at the John Wayne Cancer Institute is the technique of lymphatic mapping and sentinel node biopsy. And here the premise is pretty simple. We're trying to build on the physiologic patterns of lymph node drainage. That is, where does lymph fluid drain around the patient's primary tumor site towards which regional lymph node basins? And in this schematic here, I think one can appreciate that there are areas that have lymphatic drainage. Here, a primary melanoma site in the middle of the abdomen, that this drains to defined lymph node basins that are really individualized based on the patient. And so finite regions of skin, in this case the melanoma, the left abdomen, drains specifically to an initial node within a nodal basin or to a lymph node within different lymph node basins. And we call these lymph nodes that receive the direct lymphatic drainage the sentinel lymph nodes. Different regions of the skin will drain to different sentinel nodes, and these lymph nodes, termed the sentinel lymph nodes, represent the most likely nodes to contain metastatic disease or melanoma spread, if any are involved. And the way we do that is by mapping the flow of lymph fluid by injecting either a blue dye or a radioactive tracer or in the dermis, the business end of the skin, if you will, where the lymphatics actually begin around the primary melanoma site. And with that, here now, if I take you on a quick tour of the operating room, following that injection of isosulfan blue dye that was intradermally injected, one can see here the afferent lymphatic vessel, the lymphatic vessel leading to the sentinel lymph node, and you can see the artificial blue color of this in contrast to the small rightmost portion of the lymph node where it looks somewhat fleshy, light fleshy colored, and that would be the normal tone of this lymph node. And you can see how resounding it is in terms of a color difference with this blue dye. So the sentinel lymph node biopsy procedure is to remove that lymph node and then assess it in the pathology lab. Here's an example of a microscopic metastasis of melanoma just under the capsule of this lymph node. And this pink line, if you will, near the top of the screen going from left to right in a curved fashion is the capsule of this lymph node. The whitish area above is fatty tissue just outside the lymph node, and the dense area of a lot of dark dots are mostly lymphocytes and other immune cells inside the lymph node, and you can see these large cells that are somewhat pale between the arrows, and that represents a microscopic deposit of melanoma. And that's our goal. If it exists, we'd like to find it early. We'll come back to that rationale a little bit later in the talk. Early on, we only were able to use the blue dye, and on the left is an example of a 2-centimeter margin of excision that's been proposed just prior to the wide excision around a melanoma biopsy site just on the ankle, and you can see how the blue dye is administered. On the right side of the screen here is a relatively generous incision that would have represented an incision back in the early 90s when the blue dye alone approach was used. And you can trace the blue lymphatic vessel leading to a blue stained lymph node, and that lymph node would be removed as the sentinel lymph node. That was clearly a good strategy, but not a great strategy, because about 15% of the time we weren't able to find even a single lymph node, and it was a somewhat invasive way to try a minimally invasive approach. And so two techniques over the years have improved our ability to localize the sentinel lymph nodes. One is a nuclear medicine roadmap test called Preoperative Lymphoscintigraphy, or imaging of the lymphatics prior to surgery. And the other is actually taking some of this technology into the operating room, where we can use a device called an intraoperative gamma probe that serves to a large extent like a fine-tuned Geiger counter. And here's what I mean by that. Here's an example of a preoperative lymphoscintigraphy in a patient who has a melanoma in the middle of the back. If you look at panels C and D, I think you could appreciate the outline of a patient who's turned to their side, and there's a black, what looks like a black blob, for lack of a better word, on the back, and that's actually the area of radioactive tracer that's been highlighting the primary tumor site. That was injected into the dermis, and that radioactive tracer gets taken up by the lymph fluid. And if you look now at panel B in the top right corner, you can appreciate, I think, that there's a band-like distribution of lymph fluid from the central back melanoma site to areas that are highlighted by the white and black arrows. And now if you move to the top left panel A, this is now looking from the front of the patient and assessing for the radioactive uptake. You could see in the outline of the patient with their arms upstretched, the neck in the middle at about 12 o'clock on the screen here in this panel, and the left axilla with the white arrow, the black arrow highlighting the right axilla, and you can see these areas of dark intensity, and those are areas of increased radiotracer uptake activity where the lymph nodes were actually hanging on to the radioactive isotope, and that highlights that in this particular patient we would be addressing for risk of lymph node spread in both the left and right axilla, so under the left and right arms. And now moving back into the operating room, this is a patient who has a melanoma on the flank area. They're actually lying on their side in the operating room. They're asleep, and they've already been injected around the melanoma site on their flank with both the radioactive tracer and the isosulfan blue dye that I showed you before. Here the surgeon is holding an intraoperative gamma probe, and on the right of the first panel above the words initial scan is actually the upstretched arm. So this is the axilla, and now moving down to the lower left panel, one could see with a small incision, only about an inch in length, a blue lymph node that's been identified. And then moving now to the top right panel, one could reintroduce the gamma probe after that lymph node is removed, rescan the area, look for additional areas of increased radioactive radiotracer uptake activity, and here another blue stained lymph node was identified and removed. And often the blue dye and the radioactive tracer move in a similar fashion. We call that co-localizing, and that helps us to provide both visual and audible cues as to where these lymph nodes reside, because in obese patients this could be actually quite deep, and we're trying to do less surgery rather than more to minimize the morbidity of the surgery, but to maximize the information gained. And so the reason why it's so important to adequately identify all the lymph nodes that are at risk is shown here. So in this same patient who has a melanoma of the flank, this is now a schematized view of the axilla, the armpit area. The arm is outstretched, and if one follows the two blue lines from the bottom of the screen to blue-colored lymph nodes deep within the axilla that are surrounded by yellow halos, those are lymph nodes that actually receive direct lymphatic drainage to lymph nodes from the primary site, and those we would term the true sentinel nodes. In contrast, the surgeon may inadvertently remove solely the most superficial lymph node that's stained blue. And if one follows the pathways here, one sees that this lymph node labeled secondary echelon node, which is not really a sentinel node, is not receiving drainage from the primary tumor site, but instead is receiving drainage from one of the sentinel lymph nodes. And if this was the only lymph node removed, it would be an inadequate way to stage the overall risk of this patient's possible occult microscopic disease in this lymph node basin. So overall, our tumor thickness groups from less than 1 millimeter in tumor thickness to over 4 millimeters in tumor thickness. And overall, the risk of a positive sentinel node, that is microscopic disease in the regional lymph node basin, increases with increasing tumor thickness. And another important feature here to recognize is that, for example, for patients with a 1 to 2 millimeter melanoma, we could see that the risk of a positive sentinel node in a patient with an ulcerated primary is about 23%, versus a non-ulcerated primary is closer to 9 or 10%. And that's essentially the paradigm that we see for any tumor thickness. That is, a patient with an ulcerated primary tumor has an increased risk of a positive sentinel node compared to a patient whose tumor is the same tumor thickness but without evidence of ulceration. And so putting this together, over time, there's been an evolution in how melanoma presents when it presents with evidence of regional disease at presentation. More historically, lymph node disease identified at the time of initial diagnosis was clinical. Someone was able to palpate a lymph node under their arm, in their groin, in the neck area, for example. But more recently, with the advent of sentinel node biopsy, we've learned that a fraction of patients actually have occult or hidden microscopic disease that's only detected under the microscope, as by sentinel node biopsy. And so, taken together, in the most recent edition of the American Joint Committee on Cancer database, published now about 5 years ago, about 4 out of 5 patients who presented with regional disease at initial presentation actually had microscopic disease, not clinically evident, also known as macroscopic disease. And so this technique has really afforded us the opportunity to identify early regional nodal disease compared to in years past, with much less morbidity than a formal lymph node dissection for all patients who were thought to have some risk of lymph node disease. So if we think about now current standards, for patients with a positive sentinel node, so microscopic melanoma in the regional lymph node, a recommendation for formal early therapeutic lymph node dissection, and you could think of a lymph node dissection as a clearance based on anatomic landmarks of the fatty tissue containing lymph nodes. And rather than honing in on the lymph nodes that are either radioactive or blue stained, here we're clearing anatomically defined landmarks, removing all the tissue, and then allowing our pathology colleagues to identify how many lymph nodes have been removed and whether any of them contain microscopic disease. The goals of this are to complete staging for regional nodal control and a possible survival benefit. And a landmark clinical trial called the MSLT-1 trial, or the Multicenter Selective Lymphadenectomy trial, assessed the survival benefit, among other things, in patients who had sentinel node biopsy at the time of their initial wide excision versus patients who had wide excision only, did not have any kind of evaluation of their lymph nodes with the sentinel node biopsy technique, and then had lymph node dissection down the road only if they had clinical evidence of regional disease. And overall, there were no overall survival differences in patients who had the wide excision alone versus wide excision and sentinel node biopsy, but among the patients who developed regional disease at any time, those who had regional disease identified by wide excision and sentinel node biopsy and demonstrating involved lymph nodes, involved sentinel nodes, had a more favorable survival than patients who had a wide excision only and then later failed with regional disease that was identified clinically. And so with this, we've also learned that among patients who have a lymph node dissection following a positive sentinel node, that most patients have no additional lymph nodes identified at the time of their completion lymph node dissection, which begged the question of whether completion lymph node dissection is necessary in such patients. And there are two clinical trials that are currently ongoing. One is the MSLT2 trial. It's a randomized prospective trial that randomizes patients who have had a positive sentinel node to either completion lymph node dissection of the nodal basin that harbored the positive sentinel node, or observation of the nodal basin over a period of follow-up. That trial has been completely accrued and now is in a follow-up mode, and it'll probably be in a follow-up mode for at least another 2 to 3 years before any follow-up data is presented. Another trial in Europe, sponsored by the European Organization for Research and Treatment of Cancer, is a registry-based trial, so this is not a randomized trial, called MINITUB for minimal tumor burden. And this is an assessment in a registry fashion of patients who have very limited tumor burden in their sentinel nodes who are observed without surgery. And this trial is also currently in a follow-up mode as well. I'd like to move on now and look at other types of important manifestations of regional disease for which surgical approaches are also sometimes employed. And these include local, satellite, and in-transit metastases, all manifestations of lymphatic spread that are different than regional node disease, in that in these cases the disease is often between the primary tumor and the draining regional lymph node basin. And you can see here that in-transit disease can be a very significant problem for the patient. There are many treatment options for in-transit melanoma that include local treatments like surgical excision or intralesional therapy, regional treatments that include some form of limb perfusion or infusion, which we'll talk about in just a minute, as well as systemic approaches. And I'd like to try to put this in a little bit of perspective. And so when we think about the role of surgery in in-transit disease, resection and regional approaches have been a common mainstay of treatment. The resection is often for limited volume disease that presents in a way that's amenable to surgical resection, whereas other regional approaches are more commonly employed classically when there are multiple lesions that are not amenable to surgical resection or other treatment approaches. The earliest of these regional approaches is called hyperthermic isolated limb perfusion. Essentially, it's a fancy approach to delivering high doses of chemotherapy to the affected extremity. So in this schematic here, this patient's right lower extremity is studded with in-transit metastatic melanoma. The primary melanoma may have been on the foot, for example, here. And by isolating the blood vasculature, the circulation to the extremity, using a type of tourniquet, and then inserting tubes surgically that help to allow circulation in the isolated extremity, one can oxygenate the circuit, one can deliver high doses of chemotherapy and actually circulate warmed chemotherapy for about an hour. The advantage of this is that high doses of chemotherapy that otherwise may not be so well tolerated because of risk of toxicity to the rest of the body could be administered to where it's needed the most, and that would be to the area where there is a disease, and try to spare vital organs of the chemotherapy to try to minimize systemic toxicities. Nonetheless, there are potential significant side effects that can occur in the leg, but given the challenges of treatment over the years, this had been a widely employed approach. More recently, over the last 20 years or so, Professor John Thompson at the in Sydney developed a minimally invasive approach to regional therapy called isolated limb infusion. This is the same overall approach in that regional chemotherapy is administered. In this case, the catheters or tubes are administered by the interventional radiology team, and the tourniquet employed is similar to a very tight blood pressure cuff. And so there's a less invasive surgical approach in this way. There are other methodologic differences that I won't go into. It's a shorter infusion time, but it can actually be repeated if necessary at a later date. The chemotherapy is generally a similar nitrogen mustard or melphalan that's used for the regional perfusion studies that I just showed before. The advantages of this minimally invasive isolated limb infusion are that it's technically easier. It can, in theory, be performed with regional anesthesia instead of general anesthesia, although most people still use general anesthesia. It's generally well tolerated, although there is some risk to the extremity of complications. Blood transfusions are not required, whereas they are for some of the priming of the pump, if you will, for the more bold limb perfusion approach. And to a large extent, there are similar responses in terms of response rate to the limb perfusion. I'd like to move on now and talk about a newer area of therapy that many of the surgeons have been involved in the clinical trials over the last handful of years, and that's injectable intralesional therapy. Goals here are to locally ablate the disease for local disease control. There's a high local concentration of the agent since it's being injected into the tumor itself. That's what intralesional means, and can often be used for palliation and local symptom control for patients who have other disease as well. Another goal would be induction of a systemic host immune response. So if the injected agent can help instill and incite an immune response, then there may be responses of other regional and distant metastases that were not specifically injected. And by focusing our attention to injectable lesions, there may be limited systemic toxicity, whereas many systemic agents historically for melanoma have been associated with a potential for toxicity. In addition, for patients who have stage 3B or stage 3C disease, for example, this kind of approach of intralesional therapy, if there is some systemic effect, may then prevent the development of stage 4 disease down the road. There are many intralesional agents that have been in development, and we're not going to focus on this entire landscape today. There are intralesional agents in various stages or phases of clinical trial development, and what I'm going to do is focus on the one agent that has thus far moved furthest through the clinical trial pipeline and investigation. And this is called TVEC. TVEC is a herpes simplex virus derived oncolytic immunotherapy that's designed to produce local and systemic effects. Well, what does that mean? Essentially, this agent has been engineered in the backbone of a virus to enter cancer cells, as shown on the left here, and then disrupt or rupture the tumor cells for the local cancer killing effect, also called the oncolytic effect. The therapy is designed to also support production of a growth factor called GM-CSF that, in theory, can help stimulate the immune system. And as shown here in the third panel, a systemic tumor-specific immune response can be incited by the activation of the immune system by not only the killing of cells directly, but also by the GM-CSF presence. And then ultimately, through this systemic tumor-specific immune response, the rationale is that there would be death of cancer cells at a distant site. And so the Optum Phase 3 study design included patients who had unresectable stage 3B through stage 4 disease that were injectable in location. and then randomized to either this T-VEC intralesional agent every 2 weeks or a subcutaneous injection of the GM-CSF, which the T-VEC viral therapy helped to incite within the tumor cells. The primary endpoint was a durable response rate, and other secondary endpoints were more common endpoints in melanoma advanced therapy, like overall survival and overall response rate and progression-free survival. Patients were enrolled between 2009 and the summer of 2011. And here, just to highlight how this is a different kind of therapy than many others, the T-VEC is actually administered into the metastasis, so into the either skin or subcutaneous or lymph node metastasis. In this particular study, no visceral or organ lesions injections were permitted. And then this was assessed over time. First, from a safety standpoint, while about 20 to 50% of patients had some type of adverse event, mostly generalized type symptoms like fatigue, chills, fever, nausea, flu-like symptoms, pain at the injection site. Importantly, on the right side of the screen here, the more serious or grade 3 and 4 adverse events that occurred in at least 5 patients actually occurred quite infrequently, where the most common significant adverse event was a cellulitis or skin infection that occurred in only 2% of the patients who had the T-VEC drug. So overall, a very, very well-tolerated agent. And now what about response rates? We're going to compare the control GM-CSF with the T-VEC in these two tables. And on the in the top table, we could see that the overall response rate that included patients who had either complete response or partial response was 26%, compared to under 6% in the control arm. And the durable response rate in the bottom panel was 16% for the T-VEC-treated patients versus only 2% for the controls. From another perspective, I think a picture is often worth 1,000 words. So here's an example of a patient who had, on the top panel, multiple in-transit lesions, and after cycle 13, a near complete resolution of the melanoma with just what we characteristically call ghosts, where this is likely mostly just pigment but not tumor that remains after these injections. We talked about a goal of intralesional therapy being not only response at the injected site but elsewhere. And if we follow these three figures now from the top to the bottom, the top includes injected lesions. The middle section includes the uninjected lesions that were not visceral. And at the bottom panel, the uninjected lesions that were visceral. And what one sees here in green are the significant response rates of at least 50% in each of these types of tumor groups, where about 2/3 of injected lesions had about a 50% response. About 1/3 of the non-injected lesions had at least a 50% decrease or response. And remarkably, about 15% of lesions that were visceral, so in an organ that were not injected, had a response. So this suggested that there was not only local effect, but also some regional and even some systemic effect. From a survival standpoint, there was a borderline significant difference favoring the T-VEC group in terms of overall survival. Recall, this was not the primary endpoint, but was one of the endpoints. And so taken together, this information compared to some of the other agents that have been used in an intralesional fashion actually compared quite favorably. Most notably, in this phase 3 trial, about 15% response rate in non-injected systemic lesions, about 1/3 in the non-injected regional lesions, and about 2/3, as I mentioned, in the injected lesions. So going forward, this agent has recently been the subject of a Food and Drug Administration panel review and has received some initial favorable review, and hopefully by sometime this year, we'll learn more about whether this becomes an additional agent available for use and approved for use in patients with metastatic melanoma. From a broader perspective, some of the evolving indications for intralesional therapy would include cutaneous or nodal lesions that are injectable, that are not surgically amenable otherwise. In a neoadjuvant setting, to try to reduce the bulk of the lesion and to try to incite some systemic response before surgery. For patients with limited burden stage 4 disease of the skin called M1A, possibly for patients who have M1B disease or that of the lung, although that's not as well tested. Much less clear whether there'll be a role for patients who have visceral disease like M1C disease, but may very likely be part of the armamentarium if approved for patients with poor performance status where other therapies or surgery are just not likely to be recommended or possible. It's not likely going to be part of the treatment plan for patients with rapidly progressing disease. Since there is some immune response that's been identified, that begs the question of whether this may be ripe for combinatorial strategies with some of the evolving immunotherapies that will be the subject of other talks. So what about the role of surgery in advanced disease? We'll go over some of the background and some prognostic factors associated with this decision-making process, and also discuss some of its role in this new era of targeted immunotherapy that's really been unprecedented over the last 4 years or so. So in terms of surgery for advanced disease, one of the challenges has been that the vast majority of patients with distant disease have historically had a poor prognosis regardless of treatment. But we have identified subgroups that exhibit favorable biology and long-term survival after complete surgical resection. And what do I mean by that? We'll come back to that in just a minute. And also, one of the tenets of stage 4 disease has been consideration of systemic therapy, because one presumes often that there may be surgically unresectable disease, either at a microscopic level or based on the presentation of a patient with widespread disease, where surgery would not likely ever be a likely source of first approach to advanced disease. To put things in a little bit of perspective, the American Joint Committee on Cancer staging system for stage 4 or distant metastatic disease includes M1A, B, and C. M1A, distant skin, subcutaneous, or distant nodal metastasis. M1B for lung metastasis, and M1C would be all other non-pulmonary visceral sites, including other organs, or any patient who has a distant metastasis with an elevated serum lactate dehydrogenase level, or LDH, which is an adverse prognostic feature in patients with distant melanoma. So in terms of prognosis, in addition to the site of the disease, other factors are also important, like the number of sites, the number of nodules, the tumor doubling time, the length of disease-free interval, and whether a complete resection can be rendered. Standard therapies for metastatic melanoma, to try to put this discussion of surgery in context, include immunotherapies like anti-CTLA-4 and the recently approved anti-PD-1 drugs. For patients with BRAF mutations, BRAF and MEK combinatorial inhibition strategies, clinical trial participation, or other more legacy-type systemic therapies. Surgery has often been considered a treatment option for patients with limited burden distant disease. And best supportive care has also historically been an option before the advent of effective systemic therapies. So in terms of selection of initial therapy, one needs to assess whether the disease is resectable. If a patient has a BRAF mutation, when should that be started? If a patient is eligible for immunotherapy, when should that be started? And sometimes the decision may be related to which clinicians are involved, those who have experience in these kinds of treatment modalities. And so it's an important consideration to have a thoughtful approach and a multidisciplinary approach to stage 4 disease. From the standpoint of surgery, selection has always been an important consideration. One needs to understand the natural history of and biology of melanoma and perform a thorough preoperative staging evaluation to recognize not only what the potential morbidity or side effects of the surgery are, but also what is the associated comorbidities or other health issues of the patient that might inform us on whether a surgical approach is even possible. There needs to be clear communication of the risks and benefits and goals of surgery and the expected outcomes to the patient and the family alike. And as we think about this, we want to also ask the question, is this for curative intent? That is, can we achieve a complete resection of the known disease with this planned surgery? Are there associated symptoms that might push us towards one treatment modality or another? What's the morbidity or the potential side effects of the surgery itself and the risks based on health issues of the patient? And we want to try to target the right patient population. If at all possible, we wouldn't want to offer a surgical resection for a patient where there's a high likelihood of recurrent disease in the postoperative or healing phase. So taking all of this together in aggregate form, there's been historical data that has demonstrated that in selected groups of patients offered surgery for advanced melanoma, that 5-year survival estimates of 14 to 60%, have been noted, compared to the long-term survival of only about 10 to 15% for all comers with advanced disease in the historical setting. Adjuvant therapy or therapy after surgery has been a mainstay of the treatment decision-making process for patients with high-risk early stage and stage 3 disease in melanoma for some time, since the advent of interferon back in the middle 90s as part of the therapeutic decision-making process. But should we consider adjuvant therapy after resection of distant disease? There are several proposed or ongoing adjuvant trials across the targeted therapy and immunotherapy and combinatorial therapy arenas that I won't go into in detail, but to suggest instead that another area that is worth mentioning today is the concept of neoadjuvant therapy, that is, preoperative systemic therapy. And this is used in other tumor types, but has historically not been so common for melanoma. And one could imagine that with an upfront therapy for patients who have advanced melanoma, if the preoperative therapy results in stable disease or response, one can consider surgery as planned, and then consider postoperative adjuvant therapy to try to further reduce the risk of other microscopic disease if it's present. For patients who have locally progressive disease without new sites, so the same operation could still be performed, one would consider surgery, for example. But for patients who have progression to other systemic sites, one might now put a strategic pause on the plan for surgery and instead consider other systemic therapy options. The potential benefits of this approach include that the metastases that have been diagnosed can serve as an in situ marker of response because the neoadjuvant therapy is employed when the tumor is still there. One could study tissue samples both pre and post-treatment using this approach. And I can't emphasize enough how important it is for the clinical research community to try to understand as much as possible about why patients respond, why they don't respond, why resistance develops, and why toxicity sometimes ensues with even the most exciting new treatments that we now have available in our armamentarium. And the other exciting part of this is because we can often learn so much in these trials, the endpoints may be achieved with a smaller number of patients. And the more that we could focus our attention to efficient trials that really help us learn whether something is moving and raising the bar or not, I think the better off we'll all be. And so what about surgery in the new era of targeted and immunotherapy? We look at this from a broad perspective. In the 70s through the 90s, there were only a couple of agents that had been approved for advanced disease, and these were associated with overall low response rates and sometimes very high toxicity. And after more than a decade of no FDA approvals for advanced melanoma after high-dose interferon in the late 90s, the immunotherapy and targeted therapy arenas were once again highlighting the importance of directed therapy in melanoma with the approval of two first-in-kind agents, ipilimumab and vemurafenib, an example of a immunotherapy and a targeted therapy in 2011, and then more recently additional examples of targeted immunotherapy through the end of 2014. This has been a very exciting time in the era of new systemic therapy. If one looks back 40 years or so, one-year survival rates for patients with advanced disease was only about 1 in 3. And now with some of the more recent clinical trial data from the past year or so, we're now seeing one-year survival rates that are approaching 90%. And one wonders how much more we can improve as we learn more and more about combinatorial strategies. It's really important to recognize how important tissue-based analysis is to gain these critical insights. And so as we think about this, here's a patient who had a BRAF mutation. We're now looking at their tumor on the left before and on the right after the initiation of BRAF inhibitor therapy. And on the top panel, the MART1 here is a stain for melanoma antigen expression, and one sees that melanoma antigens and potentially the ability for the immune system to identify these cells increased after the BRAF inhibitor therapy. And CD8 is a marker of T cells or immune cells, and one can see from the left to the right that the BRAF inhibitor therapy was associated with an infiltration of immune cells into the tumor. And now on the bottom panel here, this intensely blue-stained area is PDL1, which is the ligand of PD-1 and a subject of immunotherapy with the class of drugs called checkpoint inhibitors, where one example is anti-PD-1. So in this example here, where tissue has been used in a peri-surgery setting before and after BRAF inhibitor therapy, one could see that there are immune changes that signal a combination of BRAF inhibition and immune therapy may be beneficial. And this was all done because of the use of tissue. This is also highlighted by one of our neoadjuvant trials here at MD Anderson that one of my surgical colleagues, Jen Wargo, and one of the melanoma medical oncologists, Rhoda Maria, are leading for patients with stage 3B or stage 3 disease or limited stage 4 disease who have BRAF mutations and are randomized either on the top panel here, arm A, to upfront surgery, or on the bottom to neoadjuvant BRAF inhibitor and MEK inhibitor therapy. And as shown on the bottom, with blood draws and tumor biopsies performed before therapy, at surgery, and then potentially at follow-up or relapse, there's a massive amount of molecular and immune knowledge that can be gained by longitudinally assessing the tissue and blood over the treatment course. The goal here is across all stages of disease to ultimately develop multimodality integrated risk modeling profiles that help to better stratify patients, for example, who would benefit by surgery alone and low-impact follow-up, if you will, without any adjuvant therapy here on the top, to patients in the middle who, after surgery, might benefit by one or more types of adjuvant therapy or systemic therapy after surgery, others for whom a neoadjuvant approach may be worthwhile, and others for whom surgery is not appropriate and for whom a systemic therapy would be efficacious. And we have to recognize that despite all of our achievements to date, there are clearly some patients really who don't yet have a good fit to any model of therapy, and this represents how humble we all continue to be in the medical community, trying to continue to individualize and improve melanoma management for patients who are diagnosed with this disease. And with that, I thank you for your attention, and we'll be happy to entertain questions.
Great. Thank you, Jeff. This is Catherine Poole from MIF, and what a wonderful webinar. I certainly learned a lot from it. I have a few questions from our patients to ask you, Jeff. Would you agree that when you remove a tumor and its ability to send out what they often term as seeds to start new tumors, is that a promising solution to melanoma most of the time or just some of the time?
I'm not sure I follow that question.
Well, let me give you the flip side of it too. That there's still folks that believe that when you disturb a tumor, that you actually send out more tumor-starting seeds, so that you shouldn't disturb it with surgery. That it's better to take something systemically.
Right. So, okay. So the question is, does surgery potentially promote metastasis? And if that were the case, we probably wouldn't see the very high response rates that we do in early stage disease, as an example. And we have very limited data that would suggest that biopsies themselves from suspicious melanomas or the surgery itself actually promotes metastasis.
That's what I always thought. It's funny. That's still a thought out there, though. In what situations would you say is surgery prohibitive? What's probably the top 2 reasons you would not be able to do surgery?
So I think the most important sort of take-home is trying to have any therapy fit the patient's entire clinical situation. So the extent of the disease, the rapidity or not with which the disease has developed, the extent of the disease, the associated other health issues of the patient. And so 2 probably top reasons where surgery would not be recommended is where surgery wouldn't be able to resolve the scope or the magnitude of the disease. So particularly in the metastatic setting, when there are multiple disparate lesions that may be in different organs, for example, or in inaccessible locations, or both. And another is when health issues of the patient would prohibit us from being able to render any kind of surgical treatment safely.
Okay. And how often is a laparoscope used for tumor removal? Are you able to do that, or is that usually?
Sure, that's a good question. So partly related to when might surgery not be indicated is, when is surgery indicated and what kind of surgery might be indicated. So the laparoscope, for those of you who may not be aware, is a way to essentially look inside the various parts of the body, in this case the abdomen, with a minimally invasive approach compared to a traditional incision that would be associated with more classical surgery. And so laparoscopy is often employed for in the metastatic setting. That is when metastases are identified. If it's a procedure for which the laparoscope or a laparoscopic approach would be entertained. Not all types of surgery are amenable to laparoscopic or other minimally invasive approaches, but it's clearly part of the armamentarium in contemporary surgical oncology. And I think that one other area of surgery that is evolving is, as we've all been very excited by some of these advances in systemic therapy, is that we've also learned a lot about the biology of melanoma. And what I mean by that is sometimes we'll find that, let's say, the majority of the lesions may respond to the therapy, and there may be some holdouts, some tumors that didn't respond or that grew. And so now surgery may have a new indication for consolidating the response of otherwise, and to a growing extent now, effective systemic therapy. So let's say there were 8 lesions and only 1 remains after therapy. One can consider now going in and surgically resecting that 8th lesion if it's amenable to surgery and the patient is otherwise a candidate for surgery as a combined approach. And so this is an exciting new area where surgery may interface with some of the newer therapies, in addition to trying to learn as much as we can from the tissue itself related to treatment around surgery.
And related to that, something, this is my question that from what you were talking about today, why has melanoma been different than the other cancers and not had neoadjuvant or pre-op, treatment in the past? When is it because we didn't have, the current therapies that we have, or, we can't compare it to breast cancer, which has always had those options, I believe, and also adjuvant therapy as well, post-surgery.
Yeah, I think you're pretty close there. I think that, if it's hard to consider strongly offering an upfront systemic therapy when the likelihood of response is very low. And so now that we have a lot of excitement and a track record of some agents likely to produce significant responses, we can consider options like neoadjuvant therapy in the melanoma space compared to where it has been much more common in other cancer types where systemic therapy has proven efficacious in many settings years or decades prior to the recent lessons learned in melanoma.
Yeah, that's what I figured. Well, thank you so much. This is a very, very important tool for our patients to have, your knowledge today, and we appreciate it very much.
My pleasure.
Okay. Thank you. Bye-bye.